Bonjour, mesdames, messieurs, bienvenue, and thank you for joining us for another weekly research conference. But this is in fact the last for this session. And so just a reminder, folks, I think are all familiar with the fact that if you have any questions, please use the Q&A feature on the bottom of your screen. And you can do this during the progress of the lecture. We'll endeavor to answer them in turn. And but on the other hand, if you actually have any questions that you would like to pose in person, we will endeavor that as well. So please use the hands up feature, and then Kelsey or Allison will be able to have you join us on the panel and pose the questions and discuss the findings. And but on the other hand, if you have any technical issues, please use the chat feature, and we'll make sure that we can actually get those resolved in a timely fashion and have you join us as well. And today we are absolutely delighted that we can actually have a fantastic program by one of our eminent researchers. And so some of you may even know that there's been a big announcement just on the weekend as well. And so it is absolutely delighted that we have Dr. David Messika-Zeitoun today to give us this very special lecture. And so folks will know that in fact he is the director of our valvular laboratory, and really has provided tremendous leadership in terms of the growth of the program over the last few years when he has been here at the Heart Institute. He's a professor of faculty of medicine at the University of Ottawa. And for those who may already know that in the Ottawa Citizen on the weekend, there's a big article in which Dr. Messika-Zeitoun has been named as the recipient of the super chair, and that's the Dr. Masana endowed team chair in heart valvular disease. So that's really great honor, and so well deserved, and we're just so happy, and congratulations. So Dr. Messika graduated from medical school at Université Paris, Université Pierre and Marie Curie in 1992. He completed his training in cardiology in Paris and became assistant professor in Tenon Hospital in 1999. He subsequently then did a 2-year fellowship at the Mayo Clinic, and where he really honed his skills in valvular disease and fostered him in terms of leadership. And he returned to Paris to work at the Bichat Hospital and in the division of cardiology, and went on to complete his PhD degree in 2009, and as full professor in 2013. So that's really a very rarified honor in the European system. And so we're really fortunate to actually be able to recruit Dr. Messika-Zeitoun from Paris, beautiful Paris, to Ottawa to be the professor and particularly the leader of our valvular disease program. And folks will know that he has seminal publications in the top journals in medicine, like the New England Journal of Medicine, where he really is authored some of the most authoritative studies in valvular disease in terms of randomized trials, and also publications, European Heart Journal Circulation, amongst many others. That's set the stage in terms of how we practice in terms of valvular disease today. He's also associate editor for the European Heart Journal, extremely prestigious. And so we're so delighted. Also, he helped out in terms of chairing the sessions on valvular disease at the Toronto-Ottawa Heart Summit just over the weekend. So it's really actually with great pleasure that we look forward to Dr. David Messika-Zeitoun's presentation today. It's entitled Prevention, Progression, Prediction, the Cardiovascular Heart Valve Research Program. David, great honor, and please take it away.
Thank you, Peter, for your very nice and kind words. I would like to thank again Dr. Mesana for this incredible honor to be the first recipient of the chair with this Chan. It's incredible legacy of his vision and leadership. So thanks again, Dr. Messana. I have divided my presentation into two parts. In the first part, I would like to give you some background regarding valvular heart disease and the main issues we are facing. And in the second part, I will discuss more about the CVHD research program more specifically. Rheumatic disease has dramatically decreased in the past few decades, and now in Western countries is very rare. And most of the valvular heart disease we are seeing in Western countries are degenerative valvular heart disease. I would like to emphasize that we are seeing also new emerging valvular heart disease, and I will elaborate a little bit more during my presentation. So valvular heart disease is the next epidemic. It's a disease of the elderly. You can see the prevalence is 4% between 64 and 75, and up to 11% in patients that are 75 or older. And if you look at the population here in Canada, number of people that were more than 65 years or older in 2016 was 7 million, and it's expected to go over 12 million in 2063. This registry from Sweden have provided more quantitative assessment of the prevalence and epidemics of valvular heart disease. In Sweden, they were capable of collecting all the Swedish population, so more than 10 million, and to assess the prevalence of valvular heart disease. You can see the marked increase of the prevalence of both aortic stenosis and mitral regurgitation with age. So AS was the most prominent valvular heart disease, and just after that was mitral regurgitation. Another important study in the epidemiology of valvular heart disease is OXVALV study. In this study, they screened 2,500 individuals that were referred to the primary care. They were all more than 65 years old, and they performed a systematic echocardiogram at the level of the primary care physician. And the two most important results of the OXVALV studies is one, to show that the prevalence of valvular heart disease was 1.5 million in the UK in 2015, which is predicted to increase to 3.3 million in 2053, so more than double. And the second important result was to show that half of the patients with valvular heart disease were not diagnosed. So the two most common valvular heart disease are aortic stenosis and mitral regurgitation. But it's not that we have only COVID, we have also new emerging valvular heart disease that are emerging. The first one is calcific mitral valve disease. The second one is a tricuspid regurgitation. And the third one is atrial functional mitral regurgitation. I will not talk more on the atrial functional mitral regurgitation, but its prevalence is markedly increasing because it's associated with atrial fibrillation, and atrial fibrillation is another epidemic. And the good things with valvular heart disease is that we have less invasive options. We have transcatheter therapies that fix valvular heart disease, AS, and also mitral regurgitation, but also tricuspid regurgitation. In this paper, we collected all aortic valve replacement performed in France from the administrative database. You can see that the number of aortic valve replacement has markedly increased from 2007, almost 11,000, to more than 18,000 in 2015. And this increase was mainly due to an increase of the number of TAVR. We have extended this publication in this database in a recent publication published in the European Heart Journal. We collected 2016, 17, 18, and 19. And you can see that we continue to see the linear increase in the number of TAVR, more than 23,000 in 2019, again, due to an increase in TAVR. And we have seen now a decrease in the number of, in blue, of SAVR. If you look at the distribution of aortic valve replacement according to age, now among people that are more than 80, you can see in red that it's almost always a TAVR. So TAVR has enabled us to treat first patients that were denied any intervention, and now it's the first line therapies for patients with AS, especially in the elderly population. Another important concept in valvular heart disease is that in contrast to atherosclerosis or heart failure, we have no medical therapy, and the only treatment is an intervention, could be a valve replacement or a valve repair. And if you don't treat this patient, they die. You can see in the PARTNER 1 trial that the spontaneous mortality in patients that have prohibitive risk for surgery was 60% at 2 years, and that this mortality is divided by 2 if you perform a TAVR. And in contrast to the burden of the disease, the mortality and the morbidity, there is a little awareness in the population regarding valvular heart disease. In this survey, they interrogate almost 9,000 people more than 60 years old, and you can see that heart valve disease come very late after cancer, Alzheimer's disease, stroke, heart attack, diabetes, arthritis, and respiratory disease. And in this survey, they also ask the patient how often your family physician is listening to your heart. The stethoscope auscultation is probably the most cost-effective way of diagnosis for the diagnosis of valvular heart disease. You find a murmur, you send the patient for an echo. But if you ask a patient how often the family physician is listening to your heart, you can see that in more than 50%, both of male and female, a family physician is rarely or never listening to the heart, which is a missed opportunity for the diagnosis of valvular heart disease. If you ask physician, it's not better. In this survey, using case-based scenarios, they ask a family physician cardiologist how often they auscultate the patient. And you can see that there is an underuse of systematic auscultation again by family physician. And it's a missed opportunity. If we go back to the Oxford study, 50% of valvular heart disease are not diagnosed. Not only valvular heart disease underdiagnosed, they are also undertreated. In this community study from the Mayo Clinic, patients were living around the Mayo Clinic. They have an echocardiogram done at the Mayo Clinic showing moderate to severe mitral regurgitation. They all have access to the care of this prestigious institution. And despite that, patients with guideline-based class 1 indication for surgery, only 20% underwent finally a mitral valve surgery. And we have found very similar result in France using this administrative database. We collected all admission for with the diagnosis of mitral regurgitation in France during 3 years. And you can see again, the rate of surgery is very low. Only 8% of this 100,000 patients get an intervention within a year. 92% were conservatively managed. And the demographics are also very interesting. They are completely different from the surgical series. Mean age was 74. Half of the patients were 80 or older, 12% more than 90, with a huge burden of comorbidities. And the outcome of patients that were conservatively managed was poor. 1 year mortality, 14%, and at 1 year, 1/3 of the patients were either dead or readmitted for heart failure. And it was true for primary MR as well as for secondary MR. And we calculate the cost of MR for the community. And you can see that the burden was very high, between 300 million to 500 million euro. Same with aortic stenosis. We collected more than 2,000 patients with severe AS diagnosed at 23 centers across 9 countries in Europe. Main result of the study is to show that the population was elderly, with half of the population over 80 years. Frailty and comorbidities were common and often multiple. Patients were still referred late in the course of the disease with severe symptom LV dysfunction. And despite the TAVR was doable in all these institutions, more than 20% were conservatively managed. We don't do better with tricuspid regurgitation. Again, from this administrative French database, we collected all patients admitted with a diagnosis of tricuspid regurgitation, more than 17,000 patients. Mean age 74, half had MR, half of the patients had heart failure. Within a year, 20% got an intervention, but only half of them was a tricuspid valve intervention. So 90% were conservatively managed. And you look now specifically at a patient that underwent mitral valve surgery within a year. So the patient had significant MR, and they were referred for mitral valve surgery, and they have a diagnosis of significant TR. But despite that, in 1/3 of the cases, TR was neglected. And the outcome of patients that were conservatively managed was very poor, 5% in hospital mortality, 18% at 1 year, 1/3 dead or readmitted for heart failure at 1 year. And this was true again for patients that had a prior history of cardiac surgery or left-sided disease, as well for isolated TR. And in contrast to this high prevalence, we look at this administrative database. Only 100 patients underwent an isolated tricuspid valve surgery per year in the whole France for almost 70 million people. And the mortality rate was 10% in hospital. Same in the US, even if this series is a little bit old now, you can see that the increase of isolated tricuspid valve surgery, but the total number were relatively low. 800 patients had an isolated tricuspid valve surgery in the US in 2013. And we see again this very stable 9–10% in-hospital mortality for isolated tricuspid valve surgery. Now, regarding access and quality of care, we collected all patients that had a mitral valve surgery in France during 3 years, both DMR and SMR. We are surprised to see that the in-hospital, the 1-year mortality was high, even for degenerative MR. Mortality was 13%. It was double for secondary MR. As expected, the mortality was higher when you perform replacement versus repair, or when it was a combined versus isolated surgery for both DMR and secondary MR. And another surprising result was to show that even in the best subset, patients less than 6 years have a low 0 Charlson index. Rate of repair was only 84% and was significantly lower in female than in male, only 65% in this best subset. And the rate of repair was decreasing with age and decreasing with the Charlson mobility score index. So clearly, valvular heart disease is the next epidemics. It's a lethal disease if you don't treat the valvular heart disease, but highly curable. And we have new, less invasive transcatheter therapies. And despite that, there is a low awareness of the disease. Patients with valvular heart disease are underdiagnosed, undertreated, referred late in the course of the disease. There is inequity in access and the quality of the care which is provided, and we don't have medical therapy. What is critical for the management of patients with valvular heart disease is to accurately identify the patient with valvular heart disease, to perform a careful follow-up, and to send the patient for an intervention in a timely manner. And indeed, timing is key. We can, of course, always improve the result of the procedures, both surgery and transcatheter therapies. But if you want to have a huge impact at the level of the population, we need to improve the timeliness of intervention. And this is the goal of the CVHD clinic, to improve and increase access to care, to provide regular follow-up and timely intervention. And the CVHD research program is fully aligned with these goals to improve screening, to have a better understanding of the natural history of valvular heart disease, to develop medical therapy, to improve the timing of intervention and the result of interventions. So how to raise valvular heart disease awareness? In this one of the papers I've showed you, we compare the prevalence and the mortality rate of MR to breast cancer. They are very similar. Incidence was 58,000 and mortality was 12,000, exactly like for MR. In contrast to breast cancer, we don't have any campaign regarding valvular heart disease. Contrast to breast cancer, dementia, stroke, Alzheimer, nothing on valvular heart disease. In 2019, we were asked to be part of a workshop to build a coalition to raise awareness in Canada regarding the importance of valvular heart disease. From this workshop, we developed a small group who was in charge of looking at the strategy. One first thing that we did was to mandate the Institute of Health Economics to write a white paper regarding a recommended component for national strategy in Canada for valvular heart disease. This paper is available on the website of the Institute of Health Economics as well as on the website of the Canadian Cardiovascular Society. And we identified 9 categories, both for care issues and systemic policy issues regarding awareness and education, detection, screening, diagnosis, management, treatment, the follow-up, and also for policy issues, quality and access, organization of care, innovation, funding, and research. And in January 2022, we developed and we launched the CCS working group on valvular heart disease, again with the same aligned goals to improve detection and surveillance of patients with valvular heart disease, to improve the screening by primary care providers, to improve heart valve disease awareness in the population, and to improve patient care pathways. So I've been fortunate to chair this group since January. My co-chair are Jessica Forcillo from Montreal and David Wood from Vancouver. We have representatives all across Canada. We have industry partners. We have CCS, of course. We have trainees representatives, and we have patient representatives. And so in September, we will launch with Help Valve Voice Canada a large campaign to raise awareness of valvular heart disease in the population. How to improve now the valvular heart disease diagnosis and screening people for valvular heart disease. I mentioned that stethoscope is the first line and probably the most cost-effective way to diagnose patients with valvular heart disease. It's widely available, it's cost-effective, however, it requires some training, and you need to have expertise how to listen to the heart of your patients. To help physicians, we are working with a company to develop a computer-aided auscultation algorithm. So you record cardiac heart sound using an electronic stethoscope, and the app will tell you the likelihood of the patient having a cardiac murmur. And if it's the case, you can send a patient for an echo. And in this study, we use echocardiogram as a reference, so the gold standard for the diagnosis of valvular heart disease. And this kind of algorithm has been tested in this paper here from the group of Chicago. They have shown that the accuracy of the algorithm was good for AS and a little bit less for mitral regurgitation. However, auscultation is not perfect, even for a family physician or even for cardiologist. Sensitivity and specificity is far from perfect. The best method to diagnose patients with valvular heart disease is to perform an echocardiogram. But now we have the POCUS, a point-of-care echocardiography, which is a small probe connected just to a smartphone. This usefulness has been evaluated in several studies in different settings, here at a family level, here in nurses in Vietnam. The problem with POCUS is that the POCUS is usually performed by people that have little or no training. And the problem, so it's acquisition of the images and interpretation of the images. And to bypass that, we are developing, and we will start very soon, I hope, this tele-ultrasound screening program for valvular heart disease using remote support. Now, with the React platform, we are capable of seeing exactly remotely at the same time what a physician any place in the world is seeing on his screen from our office. And so the idea is to provide this remote support to family physician at the bedside, so in their office, to guide them in terms of acquisition and interpretation of the images to diagnose and screen patients for valvular heart disease. ECG has been also suggested as a way to screen for patients with valvular heart disease, especially AS, in this paper from the Mayo Clinic, more than 250,000 ECG interpreted. The conclusion was that AI and ECG interpretation was good for the diagnosis of moderate and severe AS. I'm not sharing this conclusion. As you can see, sensitivity and specificity was relatively average. But most importantly, if you divide into 4 groups, you miss 25% of the patient with AS, and you expose to an echocardiogram 25% of the total population, which is huge in terms of public health expenditures. Another very attractive way to diagnose valvular heart disease would be to find specific markers like the PSA for the prostate. Maybe we can have the ASP, aortic stenosis protein, to diagnose patient with AS in the blood. The issue is that the valve tissue is only few grams that are and protein are released in 5 liters of blood. So I'm not sure we can have specific markers that could be detected in the blood, but it's an area of interest. How to look at and prevent progression of valvular heart disease now. Valvular heart disease are progressive disease. You start from normal valve, develop mild, moderate, and severe AS. But what is very interesting is that the progression is highly different among individuals. And to assess better the rate of progression among patients with aortic valve stenosis, we perform this meta-analysis that has been submitted a few days ago. We collected all prospective studies looking at the progression of AS using either echo and or CT and or RCTs. We collected more than 5,000 patients, and we looked at the progression rates overall and according to baseline severity. Another aim of this meta-analysis was to show and to assess if there is a difference between sexes. And you can see from the meta-regression that the progression is faster with a degree with baseline severity, faster with severe AS compared to mild AS, and faster from moderate to mild AS. And from this meta-regression, we derive this table, which is very informative for our patient to inform them what is the rate of progression which is expected in average, and when they may reach the stage of severe AS. This table also may be very informative when you design prospective randomized control trial to calculate your sample size. And we did that for every parameters for assessment of AS by echo and by CT. So I mentioned that we were looking if there is any sex differences in terms of progression between male and female. And the reason is that there are important sex differences in AS. So if you look at this plot between degree of valve calcification and mean gradient, for the same degree of calcification, women have much higher hemodynamic impairment. So women for the same gradient have lower calcification. And the reason for that is that women develop more fibrosis and less calcification than men. In this preliminary small series paper, we showed that women were progressing faster, even after adjustment for baseline severity, which translated in the worst outcome. But unfortunately, we find only 3 studies among the 24 that were evaluating progression according to sex, and we were not able to perform accurate meta-analysis regarding impact of sex on progression, which underlines the need for further studies. And so apart baseline severity, we have a very poor knowledge of what are the determinants of the progression of aortic stenosis. This is one of the goals of the CVHD registry and biobank. So every patient coming to the Center for Valvular Heart Disease for a clinical appointment is asked to be part of research. And we collect information and we collect blood, and we do that every year. We have seen, numbers are not up to date, but almost 1,000 patients at the CVHD clinic, and 600 are already part of the registry and biobank. And to assess the natural history of AS, we can also benefit from the cohort I have built in France with more now than 1,200 patients with AS. Another study that we are performing with Pascal Terolosier and collaboration with MITRE is to look at the automatic quantification using AI of the degree of aortic valve calcification by CT. So using non-contrast CT, we are capable of measuring the degree of calcification within the aortic valve with a quantitative way and accurate way. A good thing for AS is that this measurement of the degree of aortic valve calcification is completely independent of hemodynamics. Sorry. In these papers, we have again confirmed that there is a very nice correlation between the degree of calcification and hemodynamic severity, as are measured by the valve area, the mean gradient of the peak velocity. And this degree of calcification, so this quantification of the degree of calcification by CT, which is independent of hemodynamic, is very useful for the assessment of the severity of the aortic stenosis in patients with low ejection fraction and patients with a normal ejection fraction but discordant grade. And so in this study, we aimed to develop an algorithm using AI to quantitatively measure the degree of aortic valve calcification using CT. We use 846 CT, patient with AS, but also patient with no AS as controlled. So we manually segmented the aortic valve for the total calcium score, but also we added several landmarks, which are the coronary ostia, the commissures, and the center of the valve. The results of the study are very interesting. You can see that the algorithm was accurately locating the valve as well as the coronary ostia. The segmented one are in blue, the AI are in red. And if you look at a quantification of the calcium score using AI compared to the manual segmentation, very high correlation and a good accuracy when you look at the blinded Altman. Next step, so this, when you look now, sorry, at the quantification, but this way as a dichotomic for the diagnosis of severe AS with a threshold of 2,000 for men, 1,300 for women, you can see that the accuracy of the algorithm to predict severe AS was very good, around 94%. Next step now that we have is to look more in detail regarding the impact of the segmentation and the distribution of calcification, both by leaflets, but also from center to periphery, to look at how calcium grows, the relationship between the distribution and hemodynamics, and also the impact on progression on hemodynamics. So the question is, if one nodule grows significantly compared to 3 small nodules have an increase in size, how it will impact the progression of aortic stenosis hemodynamic parameters. And ultimately, what we would like to is to predict the progression of aortic valve calcification. Pathophysiology of aortic stenosis, we have made a lot of progresses, but still a lot of unknown factors. Pathophysiology of AS involve endothelial damage, inflammation, penetration of lipid deposition, which are in this oxidized form, development of fibrosis, cell differentiation into osteoblasts, and generation of matrix calcification matrix and bone formation. Statins has been, so there is an association between cardiovascular risk factors, cholesterol, and AS, but all the randomized control trials using statins to prevent AS progression has been negative. Both the SALTIRE, the CIS, and the one performed here by Quenchan, the astronomer, were negative, showing no impact of statin on AS progression. In these studies, based on the hypothesis that there is a relationship between osteoporosis and AS progression, they use two different anti-osteoporotic drugs, the denosumab and the hyaluronic acid, to look at their impact on the progression of aortic stenosis. You have an impact on bone turnover, but no impact on progression of aortic stenosis. Because of that, so no medical therapy for AS, we are launching the COPAS pilot study. The COPAS will use the colchicine in aortic stenosis. The colchicine has been shown to prevent events in patients with coronary artery disease, both in the COLCOT and the LODOCO trials. The colchicine looks very promising in AS. First, it downregulates multiple inflammatory pathways. It inhibits apoptosis, and we know that apoptosis is one of the nidus for calcification, and it has also anti-fibrotic effect. So the COPAS pilot is a pilot study where we randomize double-blind patient to colchicine or placebo, and our endpoint will be the calcification activity using PET. And if this pilot study is positive, we will move to a larger trial testing the impact of colchicine on the progression of AS using echo and CT as primary endpoints. Inclusion criteria are relatively simple. We are looking for patients with mild moderate AS, mean gradient between 15 and 25. You need, of course, to be adult. We have excluded patients with BAV, associated valvular heart disease, CKD, liver disease, and inflammatory conditions. So if you have any patient with mild moderate AS that could be of interest for us, please contact us. And other studies are coming. We are in contact with two pharmaceutical groups to test a treatment that will reduce Lp(a). Lp(a) has shown a strong association with aortic stenosis, both in terms of genetics and as well in Lp(a) blood level. And another agent that we will hope test probably Q1 2023 is a new anti-calcification agent. I mentioned new emerging valvular heart disease, and one of them is a calcific mitral valve disease. So mitral annular calcification are calcification that develop inside the mitral annulus, especially the posterior part, but this calcification can extend into the leaflets and cause what we call calcific mitral valve disease, which can express as mitral stenosis, mitral regurgitation, or combination of both. The problem with calcification mitral valve disease is that because of the calcification, it's often a high risk or complex surgery, and that transcatheter therapies, even if they are emerging, are still imperfect for this kind of patients. In this first paper, we looked at all patients with calcific mitral valve disease in 2016 from the ECHO database, and we identified 167 patients, which is a significant number, which represents 0.5% of all TEs performed that year at the Heart Institute. Another important result of the study was to show that many patients were symptomatic, but only a small proportion of them underwent a mitral valve intervention. So most of them, despite being symptomatic, were still conservatively managed. And in this paper in press, in the Journal of American Society of Echo, we have looked at the natural history of mitral annular calcification and the development of calcific mitral valve disease. We looked at 1,100 patients that had at least 1 year apart 2 echocardiograms performed at the Heart Institute, and we looked at the progression from mild moderate AS to severe AS and the progression from mild moderate severe AS to calcific mitral valve disease. At 10 years, the prevalence of the incidence of calcific mitral valve disease was 1/3, 33%. Of course, it was higher when you start with higher burden of calcification, 71 compared to 22. What was interesting is that progression of calcific mitral valve disease and MAC was faster in female than in male. At 10 years, incidence of calcific mitral valve disease was 10%, but significantly high if you start with severe MAC. And again, huge difference between sex, with female progressing faster. MAC is an interesting disease. It's associated with cardiovascular risk factors, same as aortic stenosis. However, in contrast to atherosclerosis, there is a huge female predominance in MAC compared to CAD. And so we have started a prospective MAC cohort. We take patients with MAC, free of calcific with kidney disease, and we perform a yearly evaluation using transthoracic and CT. One area of interest would be to assess the relationship between progression of MAC and bone remodeling, which has been one of the hypotheses in one study for the progression of MAC. Now, moving to prediction. And another very prevalent and increasing in prevalence disease is tricuspid regurgitation. The prevalence of TR has been recently refined in this paper from Topilsky from the Mayo Clinic, and they have shown that the prevalence was very high, 0.55% in the total population, more in female than in male. Again, we see the increased prevalence with age as all other valvular heart disease. Interestingly, the prevalence of TR was exactly the same than prevalence of moderate of severe ES. And to further refine the management and the outcome of patients with isolated tricuspid valve surgery, we collected all patients that had a tricuspid valve intervention in France between 2007 and 2017. We collected more than 5,000 patients, and among them, 462 had an isolated tricuspid valve surgery. You can see there is a nice increase in the number of total tricuspid valve surgery performed in France in these two centers, but however, the numbers remain relatively limited compared to the prevalence of the disease. If you look at isolated tricuspid valve surgery, again, very low number, approximately 50 isolated tricuspid valve surgery in these 12 big centers in France. And we find again that the overall in-hospital mortality was 10%. But an important finding of the study was to show that there was very important disparities according to etiologies. 16% when you had a prior valve surgery compared to 5% if it was for endocarditis. However, if you perform multiple adjustments, etiology was not an independent factor of outcome, and the determinant of the outcome was the severity of the clinical presentation. And so to further refine that, we developed a score, what we call the TRI-score, based on 8 parameters to define the risk of in-hospital mortality during isolated tricuspid valve surgery. 8 parameters: age, NYHA class, right-sided heart failure, dose of Lasix, impact on the kidney, impact on the liver, ejection fraction, and impact on the right ventricle. There is a very good accuracy of the score with a marked increase of the in-hospital mortality as the score was increasing. And if we go back to the difference between the etiology, you can see that functional TR has indeed higher mortality, but also higher score, and all functional TR where the distribution of the score was right shifted compared to organic TR. So it's not the etiology which was driving the prognosis, it was a worse presentation of patients referred for surgery with functional TR. We have developed a website where you can have free access to this TRI-score, and we are working now on developing an application. Very simple. You select the parameters that are positive and you get in-hospital mortality. And we have proposed this management of TR based on the TRI-score. You have low TRI-score, you can perform surgery or transcatheter intervention if doable. If the TRI-score is intermediate, probably if doable, the transcatheter option may be the best. Surgery in selected patient. And when you have a high TRI-score, probably surgery is not the best, very good option, and transcatheter could be discussed if technically feasible. But to confirm that, we have developed the TRI-Registry, which is a national multi-center registry that we coordinate with my friend Julien Dreyfus in France. We have all these French registries We have the Mayo Clinic in Milan, Zurich, Tel Aviv, Leiden, Vienna, and we are collecting our numbers in Ottawa as well of patients that had isolated TR due to functional etiology to compare the outcome of conservative management, TriClip, and surgery based on the TriScore. Another registry that we are coordinating here, again, between France and Canada, is the Metrocare Registry. We collect all tricuspid valve interventions that have been performed in 2019. We chose 2019 because it was the last year not impacted by COVID. And we have 17 centers in Canada, 34 in France, and the aim is to assess the presentation, management, and outcome both in hospital at 1 year of patients that had mitral valve surgery in 2019, both in France and in Canada, and we expect between 5,000 and 6,000 patients. There have been a huge development of both surgical therapies and transcatheter therapies that can mimic what is done by surgery, but so you can perform an annuloplasty, edge-to-edge, or replacement, both by surgery or by transcatheter therapies. The problem is that with more options, choice are even more difficult, and we need to individualize the treatment that we are providing to our patients. To assess for that, we are partnering with a French startup to predict the result of the MitraClip in patients with mitral regurgitation. We have first worked with this company to simulate the normal mitral valve. So you segmented the valve using echo as reference, and you applied physics regarding hemodynamic and forces to modelize the functioning of the valve. We started with normal valve, and we moved in the second phase with patient with mitral regurgitation. And the aim of this study now, as a third phase, is to compare the simulation of the implantation of the clip compared to what can be done, what will be done in the cath lab by our colleague interventional cardiologist. So we will have 5 centers in France plus us comparing the result of the simulation to the result of what is really done in the cath lab. Sorry. Oh, we skipped that one. So nothing could have been done without the team. So I would like to thank all the CVHD team, Donna, Leah, who just retired, Cindy, and all of them, the MD that are part of the CVHD, the incredible work of the residents and fellows, and special thanks again to Dr. Messana, without whom I will probably not be there today. Special thanks again to Dr. Bindlands for his continuous support and help since 2018 when I arrived here. And before I stop, we are looking actively for a research coordinator to help us to continue to build that program. So if you are aware of someone looking for a position as research coordinator, please contact us. And I will be very happy to develop more partnership regarding with basic scientific regarding both the pathophysiology of valvular heart disease as well as for biomarkers for presence of valvular heart disease, progression, and prognostic. Thank you for your attention.
Oh, thanks so much, David. This is a real tour de force in terms of covering the entire, really, valvular disease, not only in terms of the different types of valvular disease, but in terms of the, all the way from genetics to inception, in terms of early detection, novel technologies, and the way in which, we actually make clinical decisions. This is just a fantastic overview. And so I would like to entertain questions. Okay, so Mark Ruel would like to apply to be your coordinator, and I think he's eminently qualified, and I think we'll leave that conversation for you and Mark. And thanks, Mark, for the support for sure, for many different contexts as well. Any questions? Maybe I could start, so David, this is, just a fantastic presentation. And so do you think that, I guess one of the things that I was thinking that, there probably will need to be more and more individualize the decision making? You know, you already mentioned, you know, sort of sex and gender, you know, is kind of probably one, you know, component, and considering that, in fact, the valvular disease, in fact, is almost like part of a systemic disease, right? You know, it's related to kidney function, related to, you know, calcification process, many of the other things. And, you know, your risk predictors kind of begin to think about that. Do you think that, you know, as we get better, of course, you know, with the more data available and those large cohorts you have, that we may become more sophisticated, you know, in terms of knowing who, in fact, could be more rapidly progressing, and therefore earlier intervention is super important versus somebody who may have a, you know, combination of factors appears to be relatively stable, and therefore, you know, we have more time in terms of following. What's your sense on that, you know, sort of thinking?
I hope you're right, and that we will be able in the future to predict to individually predict the risk of progression. As you know, when we see a patient with AS, moderate AS in clinic, and he's asking us when I can expect to reach a severe stage, I said, we don't know.
Yes.
Because they can stay stable for years, because they can have a rapid increase, yes, or some kind of stairs, and we are not capable of predicting the progression. And one of the reasons is that we don't know what are the factors associated with prediction. So the first step, in my opinion, is to identify what is causing progression, so we can, after that, predict the risk of progression. And knowing that factors as well will be very useful to develop medications. Because if we identify something that is associated with progression, if we stop that pathway, maybe we might be able to stop progression.
Yeah, and the other question I have is that, you know, with the procedures, of course, the valves, the prosthesis, the technology, you know, continue to improve. And certainly we see the trend in aortic stenosis, that the trend is moving earlier as, you know, we have more confidence, you know, in terms of the durability, you know, in terms of the outcomes. Do you see that as a trend? You know, right now we tend to still wait until, you know, sort of some threshold is met, right? You know, and then we know that definitely the benefit outweighs the risk. And do you think that the ratio or the threshold over time may actually change for not only the aortic, but you know, for the other valvular diseases as well?
It's a very good point, and it's coming. So if we just focus on AS, waiting for the triggers for intervention is waiting for problems. So you're waiting for LV dysfunction. You don't want that to occur. You're waiting for significant symptoms. You're waiting for heart failure. So we have already 2 small randomized control trials in AS showing that if you do prophylactic intervention, patients do better. And it's the same in Metrocare Registration. We don't have randomized control trial, but we have observational registry showing that if you do prophylactic intervention, especially in experienced hands, and if you have low risk for surgery, and if you have high likelihood of repair, patients do better if you do a prophylactic surgery for CVMR than waiting for atrial fibrillation or heart failure. So the answer is yes. We are moving that way to perform earlier intervention, both in AS and Metrocare Registration. And there is even one trial that has just started in patients with moderate AS. So the question is that if you intervene in patients that don't even have severe AS, do you improve the prognosis?
Very important points, yeah. Now, I do have actually a number of questions. So I got a message that Dr. Rob Cushman had his hands up. Is Rob able to pose this question?
Can you hear me, Peter? Can you hear me, Peter?
Yes, absolutely. Okay. Thanks, Rob. Okay. Yes.
Okay, first of all, David, congratulations on the valvular chair there. That's terrific. And I must say, I missed your presentation at both board meetings, so I'm glad I was able to catch it today. I had some conflicts. Anyway, super. And I mean, the few questions I had, invariably you asked them, you answered them 4 or 5 slides later, just how we get out into primary care and the better technologies to do so and the educational piece. So this is terrific. I do have one question. I worked at and this may be sort of totally off the wall, but out of curiosity, I worked at a big African hospital for 3 years, and we saw a lot of rheumatic valvular disease. So your point about the sex differential, do you know, or do you have any memory as to whether there is a sex differential with valvular disease, the severity of valvular disease and rheumatic fever? I don't have any idea.
For rheumatic fever, I don't know, but for rheumatic heart disease, yes, for sure. And we know that for mitral stenosis, it's very much more common in women than in men. I think the rate is 80% female, 25% male. So there are some significant differences as well for rheumatic heart valve disease.
Okay, thank you. Appreciate it. Congratulations, great work.
Thank you very much.
So maybe we can, so I do have a question from Mark and then followed by Quan Chen. So Mark, would like your opinion in terms of valve replacement for moderate AS at the time of coronary bypass surgery. And so, and this is, in the guidelines, I think it was 2B or something like that. And what's your thinking? Because, the literature, I think from Mark's point of view, doesn't capture that these patients, will prefer, in fact, these things are actually looked after together, rather than having a repeat surgery afterwards. So what's your kind of opinion in terms of when you're facing these type of combination of settings? Yeah.
So the question is more when to do a combined intervention when you have you do the surgery for CAD and you have moderate AS. First, you have to individualize the decision, of course, but first is age. The second consideration is that we can do TAVR now, which is much less invasive than surgery. And the third consideration, I would look at the valve. So if the valve is already heavily calcified, and I would do a calcium score, even if the gradient is in the 20s, I would be more in favor of doing that at the same time. If the calcium burden is relatively low, the risk of progression is probably relatively low. And especially if the patient is old, I would leave it. And there is nothing, Mark knows that better than me, there is nothing for free. So if you do 2 interventions, the risk is also higher. So it's not that you are here, you do it, you increase cross clamp time, so you increase the mortality and the morbidity after surgery as well.
Yeah, okay, so very good illustration of the, I guess it's like, individualized, decision-making in terms of risk assessment. Thank you. Yeah, so I think that was well appreciated. Quan Chen has a question is, why the bicuspid aortic valves are excluded, from the typical prevention studies or earlier intervention, and sort of they do actually have a significant risk. And any thoughts on that?
Not sure to understand what kind of intervention is talking about. The COPAS trial? Or?
Yes, I think so. Yeah.
The reason for the COPAS is that it's a very small sample size. It's only 24 patients. And we wanted to have a pure population. It doesn't mean that we will not test the constitution in BAV, but for the pilot with a very small number, we wanted to have a very pure population without BAV. But Quan is right, and BAV has even more calcifications than tricuspid valve. So if we can have an impact on BAV as well, it would be great. So we will, if the pilot study is positive, we will not exclude BAV in the big trial. Okay,
so it's not really exclusion from principle, it's really just a sample size issue. Yeah.
With 24, if you had heterogeneity, you may not see any result.
Yes, absolutely, yeah. Maybe the last question that I would ask David, that is that, and that has to do with post-intervention, sort of improvement. And then we heard this, during the Heart Summit on the weekend as well, when people talk about frailty, talk about the possible, sort of a hidden diastolic heart failure, infiltrated heart disease, amyloid, and things like that, and so that because we do actually see more, since we do more of the TAVR, that some patients, just do fantastically afterwards. And other patients really struggle and the symptoms, don't seem to actually dramatically improve, and wonder that in fact something else was causing the symptoms. So do you have a sense as to how to, I guess, better target those responsive patients and trying to identify, I guess, what the link between the hemodynamics, which we make decisions on, and the symptomatic, limitations for the patient, because it sounds like there are some cases, two are not necessarily linked one-to-one, and so then we end up, with an unhappy patient that we have to manage.
We have all experience with a patient like that you do a very successful intervention and they remain short of breath and they're not happy. I would say that a reason for remaining short of breath could be two ways. One is that you have another disease like amyloidosis. The other one is that you perform the intervention late in the course of the disease. And we know that patients with long-lasting AS can develop fibrosis, and that fibrosis due to AS is associated with limited improvement. So the first answers to that would be to follow carefully your patient, maybe to do sometime. There is one trial evaluating surgery or TAVR in patients before they reach fibrosis to see if there is any improvement. So early intervention may prevent that. Regarding associated disease, we can screen more for amyloidosis, of course. However, the literature is showing that even if you have a combined disease, so you have AS and amyloidosis, patients still benefit from TAVR. So even if you find something, it doesn't mean that you will not perform the interventions. And so in terms of practicality, what should be done is to perform the TAVR. Of course, the patient has severe AS, to perform the TAVR, and after that you reassess symptoms. But there is no way to predict if the symptoms are more related to the AS or the amyloidosis.
Yeah, and also I think work with the patient so that they don't always expect magical returning to their 20s after the valve is done. Because
we are only fixing the valve, we are not fixing the body.
Yes, that's right. I think that's going to be a very important engagement point. Okay, wow, thank you so much. I think this is really a great treat, fantastic data, and really, helping to set the stage, right, for a lot of exciting science to come as well. So, congratulations again on your chair and on your leadership. And we look forward to really working very closely with you on this exciting venture. Yeah, so thank you so much. And that concludes actually the session for the this academic year. And so we will have a break during the summer. And so, hopefully folks can actually enjoy some rest and relaxation, after a pretty challenging couple of years. And then we'll resume the sessions in the fall. And thank you so much for joining us, and have a wonderful summer.
Thank you very much for having me, and have a wonderful summer.
Yeah, merci beaucoup. Take care.